Good afternoon, everyone, dear chair, dear audience. Before we go to our well-deserved coffee break, let's delve into diagnostics. So my PhD thesis is based on new insight of secretin-enhanced MRCP in pancreatobiliary pathologies. A little bit about me. I'm Emese Fürst. I'm a gastroenterology resident at the Institute of Pancreatic Diseases here at Semmelweis University, also a PhD student, and my supervisor is sitting at the table. So, hi, Balin. Our vision, or I do believe that when attending to a patient, care starts with an appropriate diagnosis. So my vision is to improve patient care through the improvement of diagnostic algorithms. And to achieve that, we would like to make a good use of all available diagnostic modalities in the different pancreatobiliary conditions. For that, we have specific goals. Our first project, the utilization of secretin-enhanced MRCP in pancreatobiliary pathologies, will be a systematic review and meta-analysis. And our second project will be focusing on the risk factors and the impact on the outcome of disconnected pancreatic duct syndrome in patients with acute pancreatitis. So, our first topic, secretin-enhanced MRCP. You may ask why. So, when you're a clinician and you go to the bed, you have several diagnostic tools in your hand, but you have to decide which ones to use and when. You have different imaging modalities like CT scan, MRI. Then there are the ones which are invasive and also bear with some therapeutic aspect as well, EUS, ERCP. And also there are some functional tests available. Secretin-enhanced MRCP is a bit of an odd duck here. It is shown that it can improve the visualization of the pancreatobiliary tree and also provide functional information about the pancreas, as you can see on the picture. It's unfortunate that there are no guidelines yet, even though secretin-enhanced MRCP has been with us since the late 1990s. So our aim was to study the diagnostic accuracy of SMRCP in different pancreatobiliary diseases, and we would like to identify a patient population where we can use it. So to answer the question, or to state the question, what is the diagnostic test accuracy of secretin-enhanced MRCP in different pancreatobiliary pathologies? So we stick to a PIRD framework where the population would be patients with different pancreatobiliary conditions. The index test that we're focusing on is secretin-enhanced MRCP. The reference would be the gold standard diagnostic tool for each specific condition, so ERCP, EUS, fecal elastase, and so on. And for the diagnosis of a specific condition regarding specificity and sensitivity would be assessed, and we hypothesized that there is a population where secretin-enhanced MRCP performs better than the usual diagnostic tools. So we conducted our systematic search in November in the following 3 databases with this rather broad search key because we wanted to include all articles regarding secretin-enhanced MRCP. We ended up with more than 1,100 articles, and now we're almost finished with the full text selection. We already included 162, and there's still 15 articles pending. We have finished the analysis regarding the diagnosis of sphincter of Oddi dysfunction, and there is ongoing analysis regarding biliary stones and pancreatic divism. We can say that when looking at the pooled sensitivity from the included 3 articles, that only the sensitivity of secretin-enhanced MRCP compared to sphincter of Oddi manometry is only 32%. However, for the same modalities, secretin-enhanced MRCP against manometry, the specificity is 91%. Our study has limitations. As you could see, we could only include 3 articles, somewhat heterogeneous population, and they are relatively old, all of them conducted in early 2000s. But our methods were rigorous, and all studies used the same MRI protocol, so there were no difference between the machines and the amount of secretin injected. So to conclude, our results show that secretin-enhanced MRCP has low sensitivity but high specificity in diagnosing sphincter of Oddi dysfunction. What does it mean for us? Well, first, regarding the low number of studies and relatively old studies, there should be new studies with more patients conducted. And because we're already in 2024, and MRCPs have evolved since then, maybe we should conduct new studies on better machines like 3.0 Tesla or something, because maybe it will better the outcomes. For practice, if we are right, we could implement new diagnostic protocol for suspected sphincter of Oddi dysfunction disease and also introduce secretin-enhanced MRCP in Hungary, because as of now, it is not available. So here you can see our progress with this first project. We still have to decide on 15 articles and finish the data extraction on those last two topics. So our second project would be focusing on disconnected pancreatic duct syndrome, its risk factors, and its impact on the outcome of acute pancreatitis. What is known? Disconnected pancreatic duct syndrome is an important but often overlooked complication in patients having acute pancreatitis. The literature has shown variable incidence ranging from 16 to 46%. High frequency was shown in patients with acute necrotizing pancreatitis and with patients with Waldorf necrosis. And literature also states that having disconnected pancreatic duct syndrome increases the rate of ICU admission and interventions, whether it be it endoscopy or surgery. So our aim will be to determine risk and prognostic factors for developing DPDS and investigate its effect on the outcome of acute pancreatitis. Just to sum up, we have two specific goals started last year. The first one regarding secretin-enhanced MRCP should be finished by June this year, and we're planning to conduct a prospective cohort study regarding the disconnected pancreatic duct syndrome, planned to be finished in November 2024. So thank you for your attention, and before we go and drink our coffees, it is not the answer that enlightens, but the question, said Eugene Ionesco. So, questions?
It is a good project, but I think it is very difficult in Hungary, because not just MRCP, but also monometry is very limited. The availability is very limited. The goal is great. And also the government has just started a program to bring MRI to different hospitals, so congratulations. I would like to ask you that you did not mention primary sclerosing cholangitis in your analysis. Do you have any data of this population?
Not really. When we were looking at the articles, I haven't found anything about primary sclerosing cholangitis. We found articles on anastomosis dysfunction after PPPD and a lot of conditions, but not that. But that would be interesting.